Hello, this is Yuko recording the lecture from number 3. This one is going to consist of neurobiological theories and psychopharmacology, and also movement disorders, EPS and anticholinergics, and also legal and ethical issues. So the first lecture is going to be about neurobiology. Here's your lecture objectives. You guys can read those. So the theories are about neurochemical regulation. If you recall, the synapse would be a space, let's say, between two tables. A table that sits on the north side, a table sits on the south side, with two individuals sitting at the table. Between those two tables is what is called the synapse, and that is the space where the neurochemicals are transported across for neurochemical regulation. So let's say that I throw a ball to the person at the north table and they catch it. Well, then the regulation has taken place, reuptake. Let's say they throw the ball back to me and I miss it and it goes down between the two spaces between the table. What we just have had is not any type of reuptake. All right, so dopamine pathways in the brain. Dopamine is responsible for things like compulsion, perseveration, that's where you stay stuck on things, reward. You'll see that it plays a significant role in addictions. And then serotonin is responsible for our mood, our memory, our sleep. So agonist and antagonist. An antagonist causes blockade that results in a decrease in transmission and neurotransmitter activity, whereas an agonist increases the neurotransmitter activity by directly stimulating the specific receptors. So the role of transmitters is that they facilitate neurotransmission. They're important. They have to be in the right proportions to relay the messages, because if they're disproportionate, then those messages are going to get messed up. And then you have disorders or diseases, things like cerebral palsy, multiple sclerosis, and so forth. They play a very important role in psychotropic medications, which includes their actions and also their effects. And they can be classified as being excitatory or inhibitory. So dopamine is an excitatory neurotransmitter. It's responsible for our complex movements, motivation. In low doses, in low levels, it's found in Parkinson's disease and ADHD. In high levels, it's schizophrenia and also psychosis. Norepinephrine is responsible for our attention, our learning. Low levels are indicated in depression. Elevated levels are indicated in mania and also in anxiety. Epinephrine, of course, you know, is the fight or flight. Low levels are found in depression, obsessive compulsive disorder, and also anxiety. Inhibitory neurotransmissions are serotonin. So serotonin is also known as the satiety hormone. So when we eat and we feel full, that's because our serotonin level has risen, and that's what makes us feel satisfied. So it's responsible for our ability to sleep and wakefulness and temperature regulation. And then GABA is an inhibitory neurotransmission. What it helps to do is modulate the other neurotransmitters. All right, so acetylcholine is released through stimulation of the vagus nerve, alters heart muscle contractility, but we also need it for functional memory. It can be either excitatory or inhibitory. The acetylcholine, it helps in the functional memory, especially in things like dementia. And histamines are the neuromodulators for acetylcholine. So usually what happens with serotonin syndrome, and this is something you will need to know, sorry that the little label is so little, occurs when patient takes multiple meds that affect the reuptake or the synthesis of serotonin. And so the serotonin accumulates in the neurons in the CNS. So what medications do that? Things like SSRIs, the MAO inhibitors, the TCAs, lithium, St. John's wort, Now, a patient can get serotonin syndrome without being on any type of psych meds. It may be, let's say they have a history of migraine headaches, for which they take triptans, like Imitrex, and they go out and they decide to party that night, and they do cocaine and ecstasy, and also some amphetamines. They can end up with serotonin syndrome, despite the fact they are not taking any type of psychiatric meds. So serotonin syndrome can begin within 2 hours after the first dose or several weeks into therapy. Once you DC the drug, it usually resolves itself in 24 hours. Make sure you remember serotonin syndrome because I do test heavily on it. All right, so what are the symptoms? Hypertension, tremors, ataxia, and we aren't talking a little bit of stumbling. We're talking major ataxia. They have a very hard time maintaining their balance. They fall frequently because they are not coordinated whatsoever. So they can get the sweating, the hyperpyrexia. If it gets severe enough, they may require to be put on a ventilator, in which we're going to give them things like Periactin and benzodiazepines. All right, and Periactin is an antihistamine that helps to block serotonin. If it gets severe enough, the patient can die. All right, anticholinergic toxicity. Make sure you know this as well, because I test heavily on this. It occurs from the inhibition of muscarinic cholinergic neurotransmission that causes CNS effects, peripheral nervous system effects, or both. So what are the symptoms? Psychosis, delirium, seizures, they're rare, but they can occur. Cardiovascular collapse, myoclonic jerking. The problem with anticholinergic toxicity is with the psychosis, the agitated delirium, oftentimes it may be mistaken for an exacerbation of psychosis. Additional signs and symptoms, ataxia again, hypertension. The difference with this one is they have decreased bowel sounds and a functional ileus, all right? They also can get urinary retention. If you remember, that's a medical emergency and we need to intervene immediately, all right? So they get the memory loss, they get disorientation, the confusion, and they start to hallucinate. So there's a mnemonic that goes with this. Red as a beet, dry as a bone, blind as a bat, mad as a hatter, and hot as a hare. All right? So they lose accommodation of their eyes, they get dry skin, mucous membranes dry out, they get nice and flushed, all right, and they develop a fever. All right, so that's it for this presentation. Let me get to the next one. Let's talk about some legal things, because legalities guide everything that we do as nurses. All right, you will need to know this PowerPoint presentation. All right, again, here's your objectives. So civil commitment is a commitment in which a patient presents as a danger to others, a danger to self, gravely disabled, or persistently and acutely disabled. Anybody can be a petitioner. You must have firsthand knowledge of these grounds that make the individual petitionable. They can be remanded into a psychiatric hospital against their will for 72 hours in order to be evaluated on an emergency basis. Humphrey versus Cady in 1972 said that involuntary commitment is a civil breach of their rights. Olmstead versus LC said that we need to put them into least restrictive environments such as their community. And when a patient comes in under petition, they are evaluated by a psychiatrist, and that psychiatrist makes the determination whether or not to keep the petition in place or go ahead and drop the petition. If they decide that the petition is going to stay in place, then they must get the input of a second psychiatrist who either does what's called stipulate, which means agree, or they disagree, and then they talk about what they're going to do with the patient. If both psychiatrists agree or stipulate that the patient has to go to court. And during that court hearing, it's just like a regular court hearing. The patient can call witnesses, anybody who has firsthand knowledge about the case, and the patient can make a stand against being court ordered. Also, when the second psychiatrist is called in, that psychiatrist may be somebody that the patient pays for out of pocket. So the writ of habeas corpus says you have to free the patient immediately. And that's usually, I've never seen that happen since, and all the time I've been a psych nurse, and I've been a psych nurse since 1986. There is a thing called the least restrictive alternative doctrine, which means we must put patients on a unit without restricting their freedom of movement. So what happens when a patient is court ordered? That means the patient was petitioned, the patient either stipulated, agreed, or they fight it, and then they go to court, and then the judge makes the determination after hearing testimony from all sides as to whether or not the patient is going to be placed on court-ordered treatment. If they're placed on court-ordered treatment, it is for a period of 1 year. In that period of 1 year, if they are placed on court-ordered treatment for a danger to self, they can be hospitalized acutely in an inpatient unit 90 days per year, or if they're a danger to others and persistently and acutely disabled, they may be remanded to a hospital for 180 inpatient days per year, or if they're gravely disabled, they may be court-ordered for up to 365 days per year. Make sure you remember this, please. The only individual who can declare somebody incompetent is a judge. The psychiatrist can do the workup in which he testifies as to whether or not he feels the patient is competent, but the final ruling is up to the judge. The patient, again, has the right to go to court, and the client, the psychiatrist, the social worker, the attorney, and all others provide input into the hearing, but it's only the judge who can determine whether or not the patient is competent. Ethical dilemmas. In nursing, taking no action is considered an action. Oh, this one, I'm sorry, came out really light. So 2 ethical principles. Beneficence refers to us doing good to promote the well-being of others. Non-malfeasance, abstaining from negative actions and causing any type of harm. So, ethical issues. The patient's right to refuse medication. You will need to remember this. Patients who are petitioned and patients who are voluntary have the right to refuse medication. Patients who cannot refuse medications are patients who are placed on court-ordered treatment, or they are placed on revocation or revoked court-ordered treatment. Now, I know that the word revoked means take away, and it doesn't make sense that we're going to revoke their court-ordered treatment, meaning that we're putting it back in place rather than taking it away. But what we are revoking is the patient's civil rights. So patients who are court-ordered or revoked court-ordered may have IMs administered against their will. All patients have the right to least restrictive treatment alternative. That means that we cannot confine them to their rooms. We cannot lock them in their room. If they have something infectious like MRSA or C. diff, we cannot restrict them to their room. They have the right to walk around on the unit. So, other issues, confidentiality, the doctrine of privileged communication. We have to protect the privacy of our patients. Informed medication consent. When the psychiatrist orders medication, he must have the patient sign treatment and consent for those medications, and he must be the one who discusses the effects, the benefits, and the adverse effects of those medications. And then restraint and seclusion, oftentimes what the lawsuits that occur out of that are going to be for false imprisonment. So commitment issues, again, we cannot put anyone who is 18 years or younger under petition. You cannot petition children because they're still considered to be under the auspices of their parents. You can only petition people who are 18 years of age or older. And again, remember the grounds are danger to self, danger to others, persistently and acutely disabled, and GD, which is gravely disabled. Well, all right, so types of lawsuits: breach of confidentiality, defamation of character, libel is the written word, slander is the verbal. Be very careful about what you write into a patient's chart. Remember that they have the right to see their chart. In nursing, we do not have opinions, and you do not write those opinions in charts because you can be sued for libel, all right? You can think it, but don't write it. And most certainly don't verbalize it, especially to the patient. Types of lawsuits: use of excessive force, assault and battery, abuses, okay, invasion of privacy. So assault and battery. So assault is a threat of bodily harm, and battery is where you actually make physical contact with the patient. False imprisonment is where you take their right for least restrictive movement and you violate it, and you put them maybe in a jerry chair with a tray, or you put up the side rails on their bed. You will find that on most regular adult mental health units, the beds do not have side rails. However, on general psych units, the beds do have side rails because it's considered more of a medical model than it is a psychiatric model. Okay, so restraint seclusion, make sure you remember this. Last resort. The patient must be danger to self. The charge nurse can give the order for the mechanical restraints, but she must get the order immediately from the physician. She can have up to 1 hour to get that order. You can never, never have the word PRN with the word chemical or mechanical restraint or with the word seclusion. All right, so let's look at some orders. Is this order here a legal order? No, it's not. And why isn't it? Because it has the word PRN with the word chemical restraint. Okay. What about this order? Is this a legal order? No, it's not. And why not? Because again, PRN with the word restraint. What about this order? No, it's not legal because it says PRN seclusion. All right, so these orders are legal. If you're going to get an order for any type of medication because a patient is becoming aggressive, this is the way to write the order. You're going to write a PRN for severe agitation. Never write it for chemical restraint. Here's the order for mechanical restraints. You must give the behaviors that cause the patient to go into restraint and the behaviors that are going to cause the patient to come out of restraint. The restraint time in Arizona for an adult is 3 hours. For an adolescent, it is 2 hours, and for a child, it is 1 hour. Please make sure you remember that. Here's another order. If you have a patient who is on court order and they're refusing their oral medications and you need to place them in a physical hold to administer an IM against their will, this is the way the order is going to be written. All right, so how do we avoid being sued? Most of all, make sure that we comply with the standard of care. Adhere to your nursing process. Document, document, document. I document names and I document phone numbers. Now, the reason I do that is because Let's say that there's a lawsuit that occurs 5 years from now, and in my notes I record that I contacted the house supervisor. I can guarantee you that staffing sheets get lost a lot. So 5 years later, if we go back and try to find out who the house supervisor was and we can't find the staffing sheet, then I'm sunk. How am I going to prove who it was I contacted? So I contact the name of the house supervisor. And I put in quotations what doctors say to me. I've had some of them say some very unnice things to me, and I do put that in quotations as an order. All right? Educate the patient. Make sure you're there to supervise the care. If you delegate any type of task to somebody who's a PCT, any type of tech, a CNA, an LPN, even another RN, then you should be down there supervising to make sure that they're doing the care properly. And you need to document that, because if they don't do the care in the proper manner, then they're working under your license and you're going to be held essentially liable for it. All right, so once you get your RN license, you belong to the State Board of Nursing 24 hours a day, 7 days a week. So let's say you decide to go out after work one night and you guys have a party and you get drunk, you get caught driving home drunk and you get pulled over. That gets reported to the State Board of Nursing. If you do it enough times, the State Board of Nursing can cause you to go into what's called their CAN-DO program, which is their version of drug and alcohol rehab, like basically a nursing board AA. If you continue the behavior, then they can revoke your license. Okay, so Tatiana Tarasov was a young co-ed who got involved with this young man at Santa Barbara State, and the relationship did not end very well. He was very angry, and he went to his therapist and said that he was going to get a knife and he was going to stab her to death. So the therapist went to the campus police and reported it, and they went and talked to the gentleman, and he said, yeah, you know, I said that, but I was ticked off. So they went back and they said, he's fine. You don't need to worry about it. So 2 months later, he does get a knife and he does stab her to death, hence the Tarasov Act, or also known as the duty to warn. Originally, when Tarasov was put into place, it pertained to only prominent public officials like judges, right? Because they get threatened all the time. Nowadays, if a patient comes in making any type of threat with an intent to harm against any person, that person must be notified of that potential and harm. And this is the only time under Tarasov, or the duty to warn, that you can violate HIPAA. If the patient continues to make threats against this individual, and upon discharge they are still making threats, you have to notify the intended victim that the patient is getting released so that they can make reasonable accommodation to keep themselves safe. So again, duty to warn, make sure that as nurses, we're not going to be the ones who are going to initiate the Tarasov Act. Make sure you notify your charge nurse, or you go to the social worker on the unit and also the psychiatrist or physician. Make sure you document in quotations what the patient is saying as far as the intent to harm. Make sure you document who it was you notified and that you requested an initiation of the duty to warn or Tarasov Act. That way, if anything happens and there's a failure to follow through, you have done your due diligence and notifying the individuals who needed to be notified. All right, so again, most staff nurses are not going to be doing the Tarasov. It will be the physician or social worker, or somebody who's above our pay grade. All right, child abuse. The only thing you need to know about this is we report to the Department of Family and Child Services. The good thing about Arizona is that we do have an anonymous reporting system. Okay, I do not ask you about child abuse reporting, but you do need to know about it. I'm sure Kathy covered that. Also, restraint, seclusion, things that were done to psych patients. straitjackets, which were horrible. They were put in shackles and irons. Sight patients were not treated very nicely at all. All right, remember, restraint and seclusion occurs as a last resort. All right. When a patient goes under restraint, they go on automatic 1-to-1, and their condition is reviewed every 15 minutes. We do vital signs, we do skin checks, we do circulatory checks. All right. So you must specify the type of restraint. When a patient goes into restraint, that gets reported to the state of Arizona, to the Department of Behavioral Health Licensure. And once a patient's in restraint, they have to be seen within an hour by a licensed independent practitioner. It can be the psychiatrist, or the psychiatrist can appoint the charge nurse to be the individual to go in and take a look at the patient and then document their findings that the patient hopefully is safe. Never, never, never restrain a patient on their stomach. They must be on their back. You're also going to be releasing the restraints on the patient about every half hour. Never release the same restraints on the same extremities. In other words, not both legs at the same time or both arms. Do opposite, like the left leg, right arm. All right? All right, and hold on, and we're going to go into the next lecture. All right, movement disorders. All right, I test very heavily on this as well. Movement disorders are known as EPS, or extrapyramidal symptoms. It's broken down into acute dystonia, pseudoparkinsonism, akathisia, tardive dyskinesia, and neuroleptic malignant syndrome. Here's your objectives. All right, so EPS are divided into different categories. Dyskinesias, dys meaning bad, kinesia, kinetic, are movement disorders. Dystonias, dys bad, tonia, tone, muscle tension. Tardive refers to symptoms that have been associated with long-term treatment. And oftentimes they're irreversible. All right, pharmacological treatment. The asterisks are here because these are the two anticholinergic medications that we use most commonly to treat any type of movement disorder. Benzotropine is also known as Cogentin, is an anticholinergic, and oftentimes we use it for dystonia, parkinsonism, akinesia, and akathisia. Diphenhydramine is an over-the-counter antihistaminic agent. It's also known as Benadryl. One of the benefits of using Benadryl is that it can slow somebody down, because one of the side effects, of course, is drowsiness. So you will find that there's a medication that we will give to a patient who is really agitated, and it's called a B52. So the B stands for Benadryl, usually 25 to 50 milligrams. The 5 stands for 5 milligrams of haloperidol, which is also known as Haldol. And the 2 is for 2 milligrams of lorazepam, or Ativan. And combined as a cocktail, I usually give 3 shots. I don't ever give 2, because I can never remember what I can mix in. I can't, so I give 3 shots. But when you combine all 3 of them, they're really effective at helping to slow the patient down and decrease their level of agitation. Cimetril, or amantadine, is a medication that is used for Parkinson's disease. It only has a window of efficacy for about 2 weeks. Propranolol is a beta blocker. So if a patient is using propranolol, you've got to watch them for postural hypotension, and also watch their pulse rate. Trihexyphenidyl is known as Artane. We don't use that a lot because patients know that if they chew it, it will get them high. Clonidine, or Catapres, is a very powerful antihypertensive. You have to be very careful with postural hypotension when you give this medication. So dystonias are acute, okay? They're muscle tension that causes contractions or cramps, uncontrollable. It can cause twisting of the body especially the neck. And what happens when you get torticollis is that the chin actually turns towards the shoulder. All right, it can be extremely painful. It affects any part of the body, including the eyes. So it's the rigidity, stiff and swollen tongue. They can get dysphagia, laryngospasm, which, as you know, can be an emergency, and respiratory difficulties. Oftentimes, because they can't swallow, they are profusely drooling, right? Most likely to occur in the first week of treatment in males younger than 40, especially with high-potency antipsychotics such as haloperidol and thiothoxine. An ocular crisis occurs where the eyes are rolled back in the head, and what you see when you look at the patient is the whites of their eyes, okay? All right, so it's because their medications are high potency, causing dopaminergic hyperactivity in the basal ganglia when the CNS levels drop between doses. So what's going on is that the dopamine is surging back up because it's trying to regain homeostatic balance. But remember, it's not homeostatic balance in the normal sense of the word. It's homeostatic balance in the normal sense of what the patient is used to. So if the patient is used to being psychotic, they're going to have a higher level of dopamine. So when we give them the antipsychotic, it's going to lower the dopamine, which is then going to cause the movement disorder. And then when the dopamine starts to rise back up because the medication is wearing off, the movement disorder is going to exacerbate because there's that dopaminergic rush. I know it doesn't make sense because it's a contradiction in terms. Pseudoparkinsonism is exactly that. They look like Parkinson's patients. They get that bent over, shuffling gait, slowing down. They have unusual finger movements. They can also get vocal tics, where they have uncontrollable speech or other sounds, and oftentimes you may hear them walking down the hall and going, All right, so they get bradykinesia, they slow down. Mask-like faces, it looks like a mask. There's no emotion whatsoever on their face. Cog-wheeling rigidity, if you move their hand and their arm down, it's going to feel like it's ratcheting. Fascinating gait, they lose the ability to swing their arms through when they're walking. All right, pill rolling is where they look like they're rolling pills. All right, rabbit syndrome, just like a bunny. Their nose and their mouth move just like a rabbit's would. Usually occurs within 5 to 90 days of treatment, affects twice as many women as it does men, and is caused because of the blockade of dopaminergic transmission and the nigrostriatal tract with the use of high-potency drugs with low levels of anticholinergic activity. So what do we do for it? DCE, the medication, or give anticholinergics. Akathisia, I call it wakathisia because they got to go, 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 all right? It is internal. They feel jittery. It can come on abruptly. They are not in control of it. It can be extremely exhausting and debilitating because they have to move all the time. It can become permanent. They do the sit down, stand up, or they march in place. A lot of times their families become exasperated with them, and they'll tell them, will you stop? And the patient says, I can't. And just as suddenly as it comes on, it can stop. And then the family is saying, we knew you were in control of that, but the patient isn't. So what do we do for it? Give them anticholinergics. All right, tardive dyskinesia. This is probably currently the only EPS for which there is not any type of medication. There is a new medication that is out on the market, but it's not being used very much because there have been so many adverse effects. So for the purpose of this class, I'm going to teach you that there is not any medication. The only thing that can prevent tardive dyskinesia is early detection. There's a thing called the AIMS, Abnormal Involuntary Movement Scale. It was designed to pick up tardive dyskinesia, All right. So when a patient comes onto the unit, I always encourage nurses to do an AIMS, at least a baseline, because if a patient has Parkinson's disease, how do you know once you get them on the neuroleptics or the antipsychotics, whether or not what you're seeing is an exacerbation of the Parkinson's disease, or is it one of the movement disorders? Now, I want to tell you that when patients get EPS, they don't get just one set of symptoms from one category of EPS, but they have all kinds of symptoms from all categories of EPS. All right, so this one, they do the eye blinking, they do the tongue thrust where they look like they're trying to catch flies, lip smacking behaviors, movements of the arms and legs. It can be incapacitating. Rarely does it remit in the elderly. Okay. They can get choreathoid, which are irregular movements. They oftentimes are not aware that they're doing movements. In fact, a lot of times tardive dyskinesia is even missed by the psychiatrists and the nurses because it may be as subtle as the patient just kind of smacking their lips, or perhaps the tongue thrust where it looks like they're licking their lips to moisten their lips all the time. Usually occurs in the face. It can occur around the eyes. Okay, they get the lateral jaw movements. If you ever watch a camel, how camels chew, that's what they do. They have that jaw movement. They can do the hand clenching. They can do pelvic thrusting. They can have trunk twisting and also bend backwards, which is known as the retroculpus. All right. It is more likely to occur in patients in long-term hospitals. The reason for that, how well are patients in long-term facilities monitored? Okay. It affects more women and children and individuals less than 50 years of age, and individuals with mood disorders or brain injuries more often than men. All right. So again, use the AIMS, watch the patient, pick up these symptoms early. NMS can be life-threatening. Since we're getting into the cold and flu season, oftentimes this is mistaken for the flu because the patient becomes feverish. They, of course, when they have the fever, they get diaphoretic. Their blood pressure goes up. Their heart rate goes up. What do? You give them some Tylenol, put them back to bed. The three heralding signs of NMS: profuse diaphoresis, stiffness, labile blood pressure. And I mean, it's all over. Like you can check it at 6 o'clock, it's going to be 110 over 80. You check it at 6:15, it's going to be 80 over 40. You check it at 6:30, and it's going to be 160 over 120. I mean, it is all over the place. So how do we rule it out? You're going to get a stat CBC. Their WBCs are going to be elevated. You're going to get a CPK, liver enzymes, and also order a myoglobin in plasma test, and you're going to also get a UA. Their urine will look like dark tea. It'll come back positive for myoglobinuria because the body's beginning to break down muscle tissue in order to utilize that for energy. The patient also can become obtunded, where they get mentally dull. They can become mute, or they can become agitated. So if they're already anxious and agitated, it's hard to tell whether or not it's because of NMS or because they're just agitated. What do? You need to get them to an ICU immediately so that they can get on kidney support because they're going to go into multi-organ shutdown. Usually the symptoms evolve over 24 to 72 hours, and if it's untreated, it can last for 10 to 14 days. When depot or the LAI injectables are used, the mortality rate can be 20 to 30%. So you need to make sure that you watch for this and that you catch it early. Anytime I get a patient on the unit who has any fluctuation in blood pressure or pulse rate or temperature, I put them on Q2-hour vitals because I need to be able to watch and make sure that I'm not looking at NMS. All right, so they give them smooth muscle relaxers such as Dantrium or Dantrolene, and also they can also give them bromocriptine. Okay, and that's it for lecture number 3.